Yeah, so it is a very important area, I think, as we think about risk for certain patient populations and population health management, to not have the same metrics when it comes to cost containment, because some patients are just sicker than others and will always be sicker than others no matter what you do, short of like cutting services. It's specifically very true of our HIV population who, as they age, even if they're being treated with antiretrovirals, still have higher incidences of cancer, still have higher incidences of certain acute infectious diseases. And so I think one of the kind of first benchmarks is that we have to understand and we have to allocate more resources to this population that's naturally sicker. I think we also have to, as part of that, educate our system executives and leaders that as they're looking at their dashboards and looking at certain clinics and looking at certain patient populations, that they understand that the clinical outcomes of certain patients, even with the best and most proactive population management with team-based care and kind of all the things that we'll do, that certain patients will always have a little bit more of a challenge really meeting those cost and quality metrics just because of the nature of their disease. And I see it as someone who does health system design, administrative work, and also is a clinician. I see it as part of my job to really help with the translation of that for all the individuals that are involved in this. But I think you're right. I think the question is really a good one. How do we make sure that we don't end up kind of hurting a population by, like HIV positive patients, by requiring them to meet the same metrics, the same cost metrics that are other patients who may not be as acutely ill as they are. So I think it's a challenge that we really have to kind of figure out how to deal with.